Alright, we're doing traumatic brain injury. This topic is especially important for nurses because we have often involved in every stage of care, from the emergency setting all the way through rehab and long-term support. Our goal today is to provide an overview of how TBI is assessed, diagnosed, treated, and managed from a nursing perspective. I'd like to share a short story about a family friend who had this happen. He was washing his boat and fell off the ladder, cracked his skull on the concrete. Two interesting things is he had brain swelling, which is pretty typical for the traumatic brain injury. They actually removed part of his skull and they stored it in his stomach until they were ready to do it.
So for assessment, it's really important that you rapidly assess for a TBI just to prevent deterioration and secondary injury. Obviously, these things like the Glasgow Coma Scale, which evaluates eye-opening, verbal response, and motor response. I have a video that has a mnemonic to help remember how to, all like the point system for the Glasgow Coma Scale.
Let's memorize the Glasgow Coma Score. Eyes, mouth, and motors. This just helps us remember how many points you get for each of these. Eyes get 4, mouth get 5, and motor movement, he gets 6. That is, you get 4 points if you open your eyes spontaneously. You go down 1 if you only open to speech, and you go down 1 if you only open to pain, and 1 if there's no response. Mouth, you get 5 points. That is, if you speak and you're oriented, you get 5 points. If you're confused, you get 4. If you speak inappropriately, you get 3. If you're incomprehensible, you get 2, and 1 for no response. Motors, if you obey commands, you get 6 points. If you only move for localized pain, you get 5. If you withdraw from pain, you get 4. Abnormal flexion, decorticate is 3. And abnormal extension, decerebrate, is 2. I like to remember that the word extension has an E, and decerebrate has tons of E's in it. It has 4 E's in it, so that's extension. And that's more of a sign of impending death. And 1 is for no response. So the lowest you can get is 3. Alright, so just remember eyes, mouth, and motors, and you'll be fine. Alright, I hope you enjoyed. Take care.
He's a little too chipper about TBIs, but you know.
So traumatic brain injury is defined as a disruption in brain function caused by external force like a fall, motor vehicle accident, or a blow to the head. TBIs can range from mild, such as concussions, to severe, which may result in permanent disability or even death. The Glasgow Coma Scale is commonly used to assess the severity of a TBI. It evaluates eye-opening, verbal, and motor responses and helps guide treatment decisions.
So on top of that, you also really just want to monitor your vital signs, physical examination, which I mean the Glasgow kind of does, but it's not just like a peek in. You need to be constantly monitoring these things. And then you also want to watch for more physical symptoms like pupillary changes, posturing, obviously signs of trauma like bleeding or cerebrospinal fluid leakage, and then behavioral and cognitive changes like confusion, restlessness, agitation. And then it's also important to manage and evaluate pain and sedation levels, especially if we're worried about intracranial pressure increase.
Alright, so how is this diagnosed? Diagnosis of a TBI is done through a combination of clinical assessments and imaging. Immediately you should do a CT scan because that can quickly identify bleeding, fractures, or swelling. An MRI may be used later for a more detailed view. Lab tests, neurological exams, and the serial Glasgow Coma Scale scoring also contribute to diagnostic accuracy. Nurses assist by preparing patients for tests and monitoring for any acute changes during the diagnostic process.
So for intervention, As far as acute management goes, of course you want to maintain airway patency and adequate oxygenation, and then monitoring and managing the ICP. There's many tools that you can use to monitor ICP. This second picture over here shows various different ways. When I did my rotation at Children's, there was a 3-month-old baby who had suffered from a TBI from her mom kicking her across the room. And so she had a subdural catheter to monitor her ICP. And it is crazy how delicate that whole system is. You have to, have specific millimeters of mercury. It has to be positioned a specific way. You can't touch it. You have to be really careful with repositioning a baby. And if you think like a 3-month-old who is suffering from TBI, 3-month-old are already having mobility issues with rolling around and stuff like that, but also that TBI. It just really put into perspective how serious this all is. And then my second picture is for more of like the surgical interventions. This is a pediatric craniotomy from another child who also suffered from a TBI. As you can see, it's very, very invasive, but it's a very successful intervention. Medications also play a role, like osmotic diuretics, just to help reduce that cerebral swelling. And then, like I said earlier, sedation and pain control are also essential to prevent things from getting worse.
So how is it treated? Rehabilitation is a crucial phase that can last months or even years for these patients. A lot of them here in Colorado go to the Craig Hospital, which rehabs them. Nurses support patients through physical therapy, occupational therapy, speech therapy, and depending on the areas of the brain affected. Medications can be used in the rehab phase. They can include anti-epileptics because they are prone to seizures, mood stabilizers, medications for spasticity. This is where nurses help coordinate care, educate families, and ensure medication adherence. We also support the emotional and physiological needs of both patients and caregivers during the long recovery process. Basically, from what I've seen in TBI patients, they revert back to the Maslow's hierarchy, so they're on a very basic level. They want to eat, they want to go to the bathroom, they need shelter, and sexual desire actually comes out quite a bit in them. And so you just got to remember that that's not where they're thinking in their head, that's just their baseline.
What follow-up care is needed to follow up after a TBI? It is highly individualized. It includes regular neurological assessments, continued therapy, medication management, and often adjustments in daily living needs. Nurses help evaluate the progression by monitoring for return of function or signs of regression, and we communicate those findings to the interdisciplinary team. Our advocacy is vital to make sure that patients receive the necessary home care and outpatient rehab or community resources. In conclusion, traumatic brain injuries can have lasting consequences, and nursing care plays a pivotal role throughout the entire community, from initial assessment to long-term recovery. Our ability is to recognize early signs and symptoms, implement evidence-based interventions, and support patients through rehabilitation, and it is vital for improving outcomes. It is also important to emphasize how ongoing education and teamwork across disciplinaries can make a real difference. TBIs are not a standalone injury, and it affects everyone in the system, and our care must reflect that complexity. By staying informed and advocating for our patients, we minimize complications and promote the best quality of life.